Chapter 17, Caring for Clients in Shock. Learning objectives, define shock. Shock is a life-threatening condition that occurs when arterial blood flow and oxygen delivery to tissue and cells are inadequate. Shock develops as a consequence of one of three events. 1. Blood volume decreases. 2. The heart fails as an effective pump. Or 3. Peripheral blood vessels massively dilate. The body implements compensatory mechanisms to counteract the effects of shock. When compensatory mechanisms become ineffective, shock progresses until therapeutic measures are implemented. If physiologic and therapeutic measures are inadequate, organs are damaged and death may follow. There are 4 categories of shock: hypovolemic, distributive, obstructive, and cardiogenic. Hypovolemic or hemorrhagic shock, the most common type of shock. The volume of extracellular fluid is significantly diminished, primarily because of lost or reduced blood or plasma. Because the intravascular, interstitial, and intracellular fluid volumes are interdependent, a loss from one location results in a similar depletion in the others. A deficit of intravascular volume, or plasma, reduces the net circulating volume. Hypovolemic shock can develop when overall fluid volume is depleted from significant bleeding, such as during surgery, after trauma, or after delivery of an infant. It also may result from significant fluid loss, as with burns, large draining wounds, reduced fluid intake, prolonged GI suctioning, or disorders in which fluid losses exceed fluid intake, such as diabetes insipidus. Symptoms escalate, ranging from 15%, which is 750 mils or less, loss of fluid volume, to over 40% in excess of 2,000 milliliters. Most require blood and fluid replacement when there is 30 to 40% loss of fluid. A fluid loss that exceeds 40% is life-threatening. Distributive shock is sometimes called normal volemic shock because the amount of fluid in the circulatory system is not reduced, yet the fluid circulation does not permit effective tissue perfusion. Vasodilation, a prominent characteristic of distributive shock, increases the space in the vascular bed. Central blood flow is reduced because peripheral, vascular, or interstitial areas exceed their usual capacity. 3 types of distributive shock are neurogenic, septic, and anaphylactic shock. Neurogenic shock is the rarest type of shock, resulting from injury that affects the vasomotor center in the medulla of the brain or to the peripheral nerves that extend from the spinal cord to the blood vessels. Injury to the spinal cord or head or overdoses of opioids, tranquilizers, or general anesthetics can cause neurogenic shock. The tone of the sympathetic nervous system is impaired, resulting in decreased arterial vascular resistance, vasodilatation, and hypotension. Because blood remains distributed in the periphery, the heart does not fill adequately. Cardiac output is reduced, tissue perfusion is compromised, cells are deprived of oxygen and switch to anaerobic metabolism, and metabolic acidosis develops from an increase in lactic acid. Septic shock or toxic shock has the highest mortality rate of the various types of shock. Up to 60% of those who develop septic shock die despite aggressive treatment. It is associated with overwhelming bacterial infections. Septic shock is preceded by a systemic inflammatory response syndrome called SIRS, an inflammatory state without a proven source of infection. SIRS progresses to sepsis when symptoms of SIRS are present and an infection is proven. Severe sepsis is a pre-septic shock condition that develops when sepsis is combined with organ hypoperfusion. Once septic shock, which is accompanied by hypotension, develops, the client may deteriorate to the point of multiple organ dysfunction syndrome, a complication of overwhelming inflammation that results in massive cellular, tissue, and organ injury. Septic shock occurs most commonly in clients with gram-negative bacteremia, which is bacteria in the blood, caused by such pathogens as E. coli, species of Pseudomonas, and gram-positive drug-resistant Staphylococcus aureus and streptococcal species. Endotoxins, harmful chemicals released by bacterial cells, are probably the major cause of septic shock. They trigger an immune response in which vasoactive chemicals such as cytokines dilate the blood vessels and increase capillary permeability, causing vascular fluid shift to the interstitium. Unlike other forms of shock, clients with septic shock have an elevated WBC count and initially manifest a fever accompanied by warm, flushed skin and a rapid bounding pulse. As septic shock progresses, clients eventually develop cold, pale, or mottled skin and hypotensive symptoms common with other forms of shock. On page 244 in TIMBY, box 17-1, criteria for systemic inflammatory response syndrome, which is SIRS, is diagnosed when two or more of the following are present, and there is a strong suspicion of inflammation, such as microbial infection, pancreatitis, multiple trauma, and others. Heart rate greater than 90 beats per minute, body temperature less than 36 degrees centigrade or 96.8 Fahrenheit, or greater than 38 degrees centigrade or 100.8 degrees Fahrenheit. Respiratory rate is over 20 breaths per minute, or blood gas measurement of carbon dioxide, PaCO2, of less than 32 millimeters mercury. Normal, again, is 35 to 45 millimeters mercury. White blood cell count less than 4,000 cells per millimeter or greater than 12,000 cells per millimeter, or the presence of more than 10% immature neutrophils. Another type of shock, anaphylactic shock, is a severe allergic reaction that follows exposure to a substance in which a person is extremely sensitive. Common allergic substances include bee venom, latex, fish, nuts, and penicillin. The body's immune response to the allergic substance causes mast cells in the connective tissues, bronchi, and GI tract to release histamine and other chemicals. The results are vasodilation, increased capillary permeability, accompanied by swelling of the airway and subcutaneous tissues, hypotension, and hives or an itchy rash. Hypovolemic shock. This is the most common type of shock. The extracellular fluid is significantly diminished. The causes are blood or plasma loss, surgery, trauma, and birth. Other fluid losses include burns, large draining wounds, and suctioning. Symptoms are evident at fluid loss of 750 to 1,500 milliliters, and they become life-threatening at 2,000 milliliters. Because the intravascular, interstitial, and intracellular fluid volumes are interdependent, a loss from one location results in a similar depletion in the others. A deficit of intravascular volume or plasma reduces the net circulating volume. Hypovolemic shock can have developed when overall fluid volume is depleted from significant bleeding, such as during surgery, after trauma, or after delivery of an infant. It may also result from significant fluid loss, as with burns and large draining wounds. Also from reduced fluid intake, prolonged GI suctioning, or disorders in which fluid losses exceed fluid intake, such as diabetes insipidus. There are 4 classifications of hypovolemic shock: Class 1, 2, 3, and 4. Class 1 is a fluid volume loss of 0 to 15%, less than or equal to 750 milliliters. It manifests as minimal tachycardia, cap refill is slower, greater than 3 seconds, the person is slightly anxious, the heart rate is over 100 beats per minute. Class 2 is 15 to 30% of fluid volume loss, which is 750 to 1,000 milliliters. The heart rate is greater than 100 beats per minute. Tachypnea, meaning rapid respiration rate, is 20 to 30 breaths per minute. You have decreased urine output, 20 to 30 milliliters per hour. You have a decreased pulse pressure, where the systolic and diastolic are very close together. cool, clammy skin, decreased capillary refill, and the person is mildly anxious. Class 3 is a 30 to 40% fluid volume loss between 1,500 and 2,000 milliliters. There is a very strong tachycardia, greater than 120 beats per minute. There's also tachypnea, in this case even faster breathing, 30 to 40 breaths per minute, a decreased systolic blood pressure, oliguria, which is a very scant amount of urine, between 5 and 15 milliliters, and the patient has confusion or agitation. In class 4, which is greater than 40% of fluid volume or greater than 2,000 milliliters of loss, there's a narrowed pulse pressure or unmeasurable diastolic pressure, marked oliguria or anuria, which is very little urine or no urine, cold, pale skin, lethargic, or unconscious, and this can lead to death if not treated. Distributive shock is also known as normovolemic shock because the amount of fluid in the circulatory system is not reduced, but the fluid circulation does not permit effective tissue perfusion or getting oxygen. Vasodilatation, a prominent characteristic of distributive shock, increases the space in the vascular bed. Central blood flow is reduced because peripheral vascular or interstitial areas exceed their usual capacity. 3 types of distributive shock are neurogenic, septic, and anaphylactic shock. Obstructive shock. Obstructive shock occurs when there is interference with the circulation of blood into and out of the heart, compromising the volume of blood that enters and leaves the heart en route to the lungs and tissues. Any condition that fills the thoracic cavity with fluid, air, or tissue can lead to obstructive shock. Examples include increased fluid or blood in the pericardial sac, which is called cardiac tamponade, air that accumulates between the layers of the pleura, called tension pneumothorax, or abdominal tissue, fluid, or air that crowds the diaphragm, as in an enlarged liver and ascites, thus reducing the size of the thorax. Cardiogenic shock. The heart contraction is ineffective, which reduces cardiac output, the volume of blood ejected from the left ventricle per minute. A myocardial infarction, called MI, with subsequent heart failure is a leading cause of cardiogenic shock. Older adults, particularly those with cardiac disease, are prone to cardiogenic shock. They have a decreased percentage of body water and are more likely to develop hypovolemic shock. Due to a decreased immune response, which hinders the body's ability to fight infection, older adults may also be at higher risk for developing septic shock. Question. The client has an elevated white blood cell or leukocyte count and initially manifests a fever accompanied by warm, flushed skin, a rapid bounding pulse. What type of shock is this client most likely experiencing? Again, this is called SIRS, Systemic Inflammatory Response Syndrome, and it is diagnostic with septic shock. The rationale are endotoxins, harmful chemicals released by bacterial cells in septic shock, trigger an immune response in which vasoactive chemicals dilate the blood vessels and increase capillary permeability, causing vascular fluid to shift into the interstitium. There are 3 stages of shock: compensation, decompensation, and irreversible. The compensation stage is the first stage of shock, during which several physiologic mechanisms attempt to stabilize the spiraling consequences. If these mechanisms are successful, homeostasis may be achieved. If natural or medical means can reverse shock, the chances of an uncomplicated recovery are greatly improved. As shock progresses, positive outcomes are less predictable. Compensatory mechanisms include the release of catecholamines, activation of the renin-angiotensin-aldosterone system, and production of antidiuretic and corticosteroid hormones. Continuing with the compensation stage, Catecholamines are neurotransmitters that stimulate responses via the sympathetic nervous system. To compensate in shock, the sympathetic nervous system releases endogenous catecholamines, epinephrine, and norepinephrine into the circulation. The adrenal medulla secretes epinephrine, whereas the endings of sympathetic nerve fibers secrete norepinephrine. Epinephrine and norepinephrine increase heart rate and myocardial contractility, which may be counterproductive in cardiogenic shock because it increases a demand for oxygen by an already compromised heart. Venous return to the right atrium subsequently increases, as does blood sent to the lungs. Bronchial dilatation increases the amount of oxygenated air entering the lungs, followed by a more efficient exchange of oxygen and carbon dioxide. The renin-angiotensin-aldosterone system is a mechanism that restores blood pressure when circulating volume is diminished. In response to low kidney perfusion, blood perfusion, the juxtaglomerular cells release renin, an enzymatic hormone in the nephrons of the kidneys. Release of renin causes a series of chemical reactions that eventually produce angiotensin II, a potent vasoconstrictor that raises blood pressure. Angiotensin II also stimulates the hypothalamus to signal the adrenal cortex through the pituitary gland to release aldosterone, a mineral corticoid that promotes reabsorption of sodium and water by the kidneys, which serves to increase blood volume. Antidiuretic hormone and corticosteroid hormones. Low blood volume also stimulates the pituitary to secrete antidiuretic hormone, also known as ADH, also known as vasopressin, and adrenocorticotropic hormone, ACTH. ADH, or vasopressin, promotes reabsorption of water that the kidneys would ordinarily excrete. ACTH stimulates the adrenal glands to secrete corticosteroid hormones, which include glucocorticoids and mineralocorticoids. Glucocorticoids, such as aldosterone, conserve sodium and promote potassium excretion. Glucocorticoids help the body respond to stress. Mineralocorticoids, such as aldosterone, conserve sodium and promote potassium excretion. They play an active role in controlling sodium and water balance. Both ADH and corticosteroid hormones promote fluid absorption and retention. Fluid reabsorption and retention. Irreversible stage of shock occurs when significant cells and organs become damaged. The client's condition reaches a point of no return despite treatment. The client no longer responds to medical interventions. Multiple systems begin to fail. When the kidneys, heart, lungs, liver, and brain cease to function, death is imminent. A client is somewhat disoriented with blood pressure lower than earlier assessment and pale skin. What stage of shock is characterized these physiologic changes? Is it irreversible stage, compensation stage, decompensation stage, or primary stage? The answer is decompensation stage. In the decompensation stage of shock, the blood vessels dilate, blood pools in the periphery and into the interstitium, and cardiac output decreases and blood pressure falls. Shock assessment. The nurse monitors the client for evidence that blood volume or circulation is becoming compromised. Although shock can develop quickly, early signs and symptoms are evident during the decompensation stage. Critical assessments include vital signs, changes in mentation, skin, and urine output. Some healthcare providers use the Apache scoring system, which stands for A, acute physiology, A, age, and chronic health evaluation, to arrive at a number that reflects the severity of the client's status and predicts the potential length of stay in a critical care setting. So A is for acute, P is for physiology, A is for age, C is for chronic, and H is for health, and E is for evaluation. The most recent version, Apache 4, requires entering 27 variables that are unique to the client, such as diagnosis, age, vital signs, and labs. The data can be entered online or with a computer application. The point value increases according to the age and complexity of health problems. An increasing score correlates with a higher risk for hospital death. Arterial blood pressure. In shock, both systolic and diastolic arterial blood pressures fall because cardiac output decreases or the vascular bed increases due to vasodilation. Hypotension may be rapid and sudden or slow and insidious. For the normotensive or normal blood pressure adult, the systolic blood pressure is slightly less than 120. A systolic blood pressure of 90 to 100 indicates impending shock, whereas 80 or below indicates shock. Although it is best to obtain a blood pressure measurement using a sphygmomanometer when only a pulse rate is available, it is possible to estimate the blood pressure. To determine the presence of shock, the client's previous blood pressure must be known. Regardless of the numeric figure, a significant and progressive fall in blood pressure from baseline is serious. For example, a blood pressure of 120/82 usually is considered normal. However, if an individual with an original blood pressure of 190/112 has a blood pressure of 120/82, shock is developing. The nurse must make the provider aware of any trend, such as a significant fall below the client's usual systolic blood pressure or any trend in progressively decreasing blood pressure. Direct blood pressure monitoring, intra-arterial, is more accurate than indirect monitoring, which is the auscultatory method using a blood pressure cuff, but it is implemented primarily in critical care areas. Pulse pressure is the numeric difference between systolic and diastolic blood pressure. If a client has a blood pressure of 120/80, the pulse pressure is 40. A pulse pressure between 30 and 50 is considered normal, with 40 millimeters mercury being a healthy average. In shock, the pulse pressure tends to narrow or decrease as the falling systolic pressure nears the diastolic pressure. Pulse rate, volume, and rhythm. In shock, healthcare personnel use the pulse rate and other assessment data to identify the severity of shock and estimate the approximate reduction in blood volume. As cardiac output decreases, the compensatory tachycardia initially develops to increase the cardiac output. In neurogenic shock, bradycardia occurs because there's a loss of compensatory sympathetic nervous system response. Pulse volume becomes weak and thready as circulatory volume diminishes. In the later stages, the pulse may be slow and imperceptible. Pulse rhythm may change from regular to irregular. Hypoxia, especially when it affects heart tissue, is a leading cause of dangerous cardiac arrhythmias such as ventricular fibrillation, or VFib. Respirations. In shock, tissues receive less oxygen. In response, the body tries to obtain more oxygen by breathing faster. Rapid respirations help move blood in large veins toward the heart. Respirations are shallow and the client may be heard grunting. In early stages, the client is hungry for air, but in profound shock as death nears, the respiratory rate decreases. Temperature. Heat regulating mechanisms are depressed in shock and added diaphoresis increases heat loss. With the possible exception of septic shock, subnormal body temperature is characteristic. Mentation. Altered cerebral function often is the first sign of inadequate oxygen delivery to the tissues. Mild anxiety, increasing restlessness, agitation, and confusion can accompany shock. As the condition deteriorates, the client becomes listless and stuporous, ultimately losing consciousness. Morphine may be administered to decrease anxiety and pain. It also decreases stress on the sympathetic branch of the peripheral nervous system, which helps reduce cardiac preload. Skin. In all but the early stages of septic and neurogenic shock, the skin is cold and clammy. As peripheral blood vessels constrict to direct blood from the skin to more vital organs, the skin becomes pale. Eventually, the skin may appear mottled, which is a mix of pale and cyanotic areas lacking any uniform color. Capillary filling is longer than 3 seconds, and cyanosis, which is blue, especially of the nail beds, lips, and earlobes, can occur, indicating oxygen deficiency. In clients with highly pigmented skin, Cyanosis is more accurately detected by inspecting the conjunctiva and oral mucous membranes. Lack of cyanosis, however, does not prove the absence of hypoxia because cyanosis is one of the last signs to appear. Urine output. Reduced cardiac output decreases renal blood flow to the kidneys, which leads to decreased urine output. Vasoconstriction, the physiologic response to shock, also contributes to markedly reduced renal blood flow. In many instances, the rate of urine formation is an important indicator of the status of a client in shock. When shock is quickly reversed, the urine output usually returns to normal. Continued oliguria, which is decreased urine formation, indicates renal damage caused by reduced blood flow to the kidneys. Diagnostic findings. Arterial blood gas, central venous pressure, and pulmonary artery pressure measurements can support a diagnosis of shock. They are also used to monitor response to treatment. Arterial blood gas measurements are drawn from a direct arterial puncture or an indwelling arterial catheter. In shock, the partial pressure of oxygen in arterial blood, which is normally 80 to 100, falls below 60. The partial pressure of CO2 in arterial blood may be normal, decreased with hyperventilation, or increased with hypoventilation. A pulse oximeter, sometimes used to monitor oxygenation continuously, measures the amount of oxygen bound to hemoglobin, or the saturated oxygen level, SpO2, which normally is 95 to 100. If the SpO2 level is above 90%, it can be assumed that the PaO2 is 60 millimeters or above, which is the oxygen level in the arterial blood. CVP, central venous pressure, is the pressure of the blood in the right atrium or vena cava. It distinguishes relationships among hemodynamic variables in shock: venous return, quality of right ventricular function, and vascular tone. CVP measurements, especially trends and readings, are useful in the management of a client in shock. A normal CVP is 2 to 7 or 4 to 10, depending on how it is measured. It could be measured in mercury or water. So CVP in mercury is 2 to 7, CVP in water is 4 to 10. In hypovolemic shock, the CVP is lower than normal owing to a low blood volume. Its cardiogenic shock is above normal because in cardiogenic shock it is usually above normal because there is venous congestion due to low cardiac output. The trend in CVP measurements is more helpful than isolated readings. Pulmonary arterial pressure. Although CVP measurements indicate the status of the right ventricular function, they do not provide information about left ventricular function. Because left ventricular function is more pertinent to circulation than right, knowing fluid pressures on the left side of the heart is more meaningful. To assess left ventricular function, a 2, 3, or 4 lumen catheter is inserted into the vena cava and advanced through the right atrium and right ventricle into the pulmonary artery. The catheter is connected to a monitor from which the pulmonary artery pressure, called PAP, or pulmonary capillary wedge pressure, PCWP, is measured. Normal PAP ranges from 20 to 30 and from 8 to 12 diastolic. So 20 to 30 systolic and 8 to 12 diastolic. Normal PCWP, which is pulmonary capillary wedge pressure, ranges from 4 to 12. In shock, PAP measurements usually are low because they reflect a low volume of blood in the arterial system. Which of the types of shock is caused by severe allergic reaction or spinal cord injuries? Distributive. Distributive shock is caused by the amount of fluid in the circulatory system that is not reduced. Medical management. An aggressive treatment of conditions that predispose to shock may prevent further shock. Once shock develops, treatment depends on its type and level and usually includes one or more of the following: IV fluids, vasopressor drug therapy, and mechanical devices that restore blood circulation to cells. IV fluids are prescribed to restore intravascular volume. The total volume and type of solution and rate of administration vary according to the reason for the shock. Usually a ratio of 3 to 1 is followed. That is, 3 liters of fluid is given for every 1 liter of fluid loss. This amount stabilizes the client, replaces the deficit, and provides a reserve to prevent shock from recurring. Initially, as much as 250 to 500 mils may be infused in 1 hour. Solutions may include crystalloid solutions, those containing dissolved substances such as sodium, other electrolytes, or glucose in water. Colloid solutions, those containing proteins such as albumin to increase osmotic pressure, and blood products if blood loss has been major. Ringer's lactate, RL, and normal saline, 0.9%. Isotonic solutions work equally well with hypovolemic shock. RL is preferred lactated Ringer's in hemorrhagic shock because it minimizes acidosis. For shock involving acute brain injuries, normal saline, 0.9% is used. To ensure oxygenation of tissues, especially in cases of hemorrhage or if the hemoglobin level is 7 or less, administering whole blood or packed red blood cells is best. 1 unit of RBCs can increase an adult's hemoglobin by 1. Clients who are alert and capable of making informed decisions but refuse blood transfusions on the basis of religious beliefs such as Jehovah's Witnesses require bloodless alternatives and measures that conserve blood and its oxygen carrying capacity. Such measures include the following: drawing the minimum volume of blood for lab analysis, restricting movement and activity to only that which is essential, reinfusing the client's own blood, using lasers and electrocautery devices to minimize bleeding during surgery, administering pharmacologic agents such as erythropoietin to stimulate the bone marrow to produce RBCs, administering cyroprecipitate, factor VIII, and thrombin to promote hemostasis, which is control of bleeding using substances in the body's natural coagulation process. Drug therapy. Medical management of shock is extremely complex. Drugs are carefully titrated and used alone or in combination to improve cardiovascular status. Adrenergic drugs are the main medications used to treat shock. Vasopressors, drugs with alpha adrenergic activity, increase peripheral vascular resistance and raise blood pressure. Examples include dopamine, which is inotropin, norepinephrine, which is levophed, and metaraminol, which is aramine. They are best administered after fluid therapy increases the intravascular fluid volume. Otherwise, the vasoconstrictive qualities further impair cellular circulation, which is already compromised by the effects of angiotensin. If infusions of first-line vasopressors such as dopamine and norepinephrine become ineffective, vasopressin may be used. Vasopressin, also known as ADH, causes contraction of arterial smooth muscles, raises blood pressure, and diverts blood to vital organs. When treating shock, drugs are titrated to patient response. Because the dose can change frequently, vasopressor drugs such as dopamine are pre-mixed in an IV solution. The dosage of the drug is delivered by changing the infusion rate of the IV. Drugs with beta-adrenergic activity that increase heart rate and improve the force of heart contraction are called positive inotropic agents. Inotropic means affecting the force of muscular contraction. Digoxin, otherwise known as Lanoxin, isoproterenol, which is called Isuprel, dobutamine, Dobutrex, milrinone, Primacor, and amrinone, Inacor are examples. Many drugs have combined alpha and beta adrenergic effects. Epinephrine is an example and is the drug of choice in anaphylactic shock. Dopamine also has combined actions. Anaphylactic shock may also be treated with antihistamine or ACTH or adrenal corticosteroids to counter the allergen. Other drug categories such as antiarrhythmics and drugs that reduce peripheral vascular resistance, such as calcium channel blockers, angiotensin-converting enzyme inhibitors, and vasodilators, such as nitrates, are appropriate for cardiogenic shock. Evidence suggests that low-dose hydrocortisone reduces mortality in cases of severe septic shock. Corticosteroid use is not proven to be helpful in other forms of shock. Mechanical devices help improve cardiac output or redistribute blood. Those used in the treatment of cardiogenic shock include the intra-aortic balloon pump, IABP, and ventricular assist device, VAD. In the past, first responders used a pneumatic anti-shock garment to redistribute blood from the lower extremities to the central circulation. The use of these, however, is somewhat controversial because incorrect application or removal is life-threatening, and poor outcomes have occurred when such garments have been used indiscriminately to manage types of shock other than hypovolemic, and their application lengthens the time between field treatment of the client and transport to a trauma center. Because of the potential disadvantages regarding PASGs, a new type of pneumatic anti-shock garment known as Dynamed anti-shock trousers has been developed. In contrast to PASGs, the Dynamed anti-shock trousers are made of 5 segments of manually applied elastic neoprene that fasten with Velcro straps. This garment, which can be applied in less than 60 seconds, encloses the body from the ankles to the diaphragm. As a result of the circumferential pressure, blood is shunted to the heart, lungs, and brain, helping to reverse hypovolemic shock and stabilize individuals until blood transfusions can be administered or surgery can be performed. Prognosis and complications. When shock is treated adequately and promptly, the client usually recovers. Recovery may be tenuous, however, because of the secondary complications, which almost always result directly from tissue hypoxia and organ ischemia due to reduced oxygenation. Life-threatening complications include kidney failure, neurological deficits, bleeding disorders such as disseminated intravascular coagulation, acute respiratory distress syndrome, stress ulcers, and sepsis that can lead to multiple organ dysfunction. Nursing process for shock includes assessment, auscultate chest and abnormal lung and heart sounds, check lab results, monitor urine output. Diagnosis, planning, and interventions include decreased cardiac output, so you want to restrict activity to total rest. You want to have IV site access. For impaired tissue perfusion, you want to assess with neurovascular checks, control bleeding, and elevate the legs. This is the end of the slideshow.